Michael Dowling from Northwell Health, CEO of Northwell Health, a huge player in the New York market area, and Karen Ignagni, who's played almost every role in healthcare that you can play except provider, is former CEO of AHIP, the Health Insurance Alliance, and now a CEO of EmblemHealth. So I want to welcome both of you to the panel. And I guess I'm doing the moderating here, but I as you know, I'm hoping that this is more of a discussion. We'll go on for about 45 minutes to an hour and then open it up to the audience. So the first question I want to ask you is, as you look at the Biden agenda, and it's obviously, as I mentioned, not just the Biden agenda, but really congressional agenda, drug price regulation, expanding Medicare services, long-term care services, increasing the subsidies, and whatever else you think is likely to happen. How much of a difference do you think that's going to make, and what is your sort of assessment of it?
I think they're clearly focused on opening the door and keeping it open for people to get in, stay in sustainably into the healthcare system, number one. That explains the subsidies, that explains the ACA subsidies, making those permanent. They're temporary right now. A number of people have come in, and they're likely to go out if those aren't made permanent. And then, Zeke, as you spoke about the Medicaid expansion in the southern states, we don't have that issue here because in New York, they were very early to expand Medicaid, and we have one of two states that has the essential plan here that has worked very well as a safety net for people who are between the ACA plans and the Medicaid plans. So opening the door. I think the second large issue that the Biden administration is trying to go to, whether they will be successful or not, is the issue of prescription drug cost containment. If you look at the trajectory of all the things each one of us want as citizens, we want to have access to the latest and greatest. But the question is whether we can sustain the pricing that the pharmaceutical companies are unilaterally imposing. And there's a perverse incentive now because the pharmaceutical companies are publicly held. Holders have very significant expectations for very, very high pricing and profits for a certain number of years. And that creates a whole host of negative incentives that redound in a negative way to us on the health plan side, and of course, Michael on the hospital side as well. So this is a question of sustainability. I think the Biden administration is getting to that quite appropriately. A final point, and this is because of the wonk in me, I guess, but I do think the Biden administration is pointing to something very important that really hasn't been talked about. The issue about Medicaid expansion in the area of hearing, vision, and dental has been talked about whether we should or shouldn't from a budget perspective. But I want to come back and say now all of the research, and Zeke, you know this very well, all of the research suggests that people who are cognitively impaired, there's a high preponderance, a high correlation between that and hearing. And that is something that I think as a country we want to think about as everyone is focused on Alzheimer's, amyloids, et cetera, but that linkage is very important. I think the Biden administration is trying to get to that, but they're talking less about the healthcare specifics and more about whether in or out. Vision, similarly, I think we will see evidence of cognitive linkages. And then dental, we know the tragedies here in New York and across the country of people not having dental coverage and what it means for their overall health care. So just a shout out to those kinds of things. Zeke, I think that the focus really hasn't gotten down to the public health aspects of those issues that I think are very important.
Very good point. And I will say that I teach my Penn students all the fact that we don't cover dental and it's not part of Medicare. And they're perplexed. Yeah. But I point out that we're not unique in that. Every European country somehow dental is not part of medical. And it is one of those peculiarities that started way back when, probably in the 1880s or 1900, and has persisted.
Yeah.
And
That's right.
this is an effort to eliminate that, and it actually would put the United States pretty much at the forefront of all countries.
But if we care about
Michael,
cognition, we should talk about hearing. And as a society, we should talk about hearing.
Yeah. Michael.
Yeah, I would concur with Karen. The issue I have, there's an awful lot in that package. And the administration may be making a mistake in a lot of things by putting too much in everything, so therefore you get little. There needs to be somewhat of a prioritization. On the speech, dental, and hearing, I would completely agree, is a major priority. And I would focus in on obviously the public health issues that Karen referenced. But I want to make a bigger other issue. You asked the question from where we sit, from where I sit. I don't pay an awful lot of daily attention to it. It's Washington speak. It doesn't have an awful lot to do today about what I've got to deal with, or for that matter, for the next year or 2 years of what I've got to deal with. I come out of government. I spent 12 years in government at a high level, and so I understand the government role. But the practical aspect of care delivery at the local level is what I spend most of my time trying to figure out. I mean, how do you actually get better care to people? And so I pay attention when I know something in Washington is about to happen. I think when I know it's about to get passed, and then I can understand what the regulatory apparatus is around what they mean by what they legislated. And when you get to know what they mean by what they legislated, then I know how to react to what it is I'm getting. Because until that point, you're not exactly sure. I hope that he is successful in getting a lot through, and obviously to the extent that we and I can be helpful on that, we will. But on an ongoing, periodic, on a regional, day-to-day basis, on monthly basis, that's not where my focus is. If I were down in Washington, and when I was in Albany, when I was head of Health and Human Services of the state, I worried about that a lot. But there's a big journey between there and here. And so I just wanted to make that point, Zeke. That's not in any way to minimize what's being discussed in Washington. But, like today, we're trying to figure out how do we deal with the issues that were raised by COVID? How do we deal with the lifestyle behavioral issues? How do I deal with mental health issues? How do I get people vaccinated? How do I provide more care in communities that were disproportionately affected by COVID? That's what I'm spending my time thinking about and worrying about. And if something in Washington helps me with that, it's not going to do it in the short run, but if it helps in the long run, great. But that's where my focus is.
Okay, so let's take that, Michael. You provided a wonderful opening.
Right.
You said what you're worried about. What initiatives are you going to take to address some of the things you're worried about?
Well, first of all, let me clarify, because there's a lot of misunderstanding about what health systems are. I mean, I'm not a hospital health system. Half of my business is non-hospital. I have a lot of hospitals, and hospitals are important, and hospitals will always be important. But my expansion is primarily in outpatient, urgent care, ambulatory, and community health. I have 865 ambulatory locations. Now, I make that point because whenever you're introduced as head of a health system, everybody thinks it's just all about hospitals. It's not. 50% of my revenue and of my whole business, as I said, is non-hospital. So what am I doing? I'm working with about 11 communities in the region, dealing with all of the community health issues, opening up and trying to open up facilities in those communities, working an awful lot on the social determinants of health issues, which, by the way, I just want to make this general point. If we're interested in improving health, we got to broaden our definition of what that is. It's not just about doctors and hospitals and nurses and doctors, etc. It's about lifestyle and behavior and all those other things that affect health. Everybody knows that only about 10 to 15% of poor health can be affected by hospitals and doctors. The rest of it is what we do to ourselves, and it's the food we eat and the water we drink and the environment we're in and the housing we're in, and what we do about obesity and what we do about maternal and infant mortality. Those are the things that if we make a major impact on, will dramatically improve health in the long run. So sometimes we put our focus on the wrong things. And I know, Ezekiel, you agree with this, but there's way too much focus just on the hospital and the delivery side of it. And we have to shift our focus and broaden the definition of health. For example, I am trying to lead a national effort, and we're doing a lot of good work on it, on the issue of gun violence as a public health issue. That's something that if we don't attack that issue, you think of the mortality that results from it, the injury that results, the behavioral health that results, the family dislocation that results, all of the issues, just on that one thing alone. Yet when we talk about healthcare, we don't include that as a public health issue, which we should. So we should broaden our perspective. It's not all about how we capitate X, Y, Z. It's about what we should be doing in those communities.
So let me push you, because I totally agree. And I actually, I didn't put it in this.
Yeah.
But one of the things you might think about President Biden is his emphasis on increasing wages, more child tax credits, more earned income tax credit, increasing the amount of resources a family has, more child care. He might actually impact health more through those things than he does by changing Medicare and Medicaid.
Agreed.
If that's true, do you think, Michael, that the government or whoever ought to hold you more accountable for what you do on the social determinants of health?
I think the government should set some rules and get out of the way. They over micromanage, and I was a regulator, believe me, understand, I come from that world. There's a wonderful experiment we've just been through for the past 18 months. We handled the COVID issue pretty well. Now, you can argue all the things didn't go right. In my company, we saw 225,000 COVID patients. I had 4,000 COVID patients in my hospitals every day. We did extraordinary, innovative things during COVID. Why? Because we were fortunate that the governor relaxed and got rid of a lot of regulation that didn't tie our hands. So we could open up beds quickly. We could open up facilities quickly. We could move quickly. I was able to open up ICU beds in a conference room like this overnight. If I had to do it on the regular time, I'd have to spend 2 years getting through the approval processes. That was a little bit of a lesson here. Government should set the goals, hold us accountable for the outcome. But please don't try to tell me how to do it day to day, month to month, because government doesn't know how. The people, including my friends who are even now in Albany, because Albany has more of a direct effect than us, most of them have never been on the front lines, have no clue how a hospital operates or how ambulatory care operates. And so, in answer to your questions, yes, we should be held accountable, but lay out the target, develop plans over a 5-year period of time, because you need that amount of time to get something done. You can't do it year to year. I proposed to the state some years ago that I would take responsibility for Medicaid patients in a whole geography in New York. I said, tell me what you want me to achieve, give me a 5-year contract. But they cannot work on a 5-year contract. They do it by yearly appropriations. Every year, there's a budget process. So yes, hold us accountable, set the goals, let us do it, don't get into the tactics, and don't micromanage.
We come at this in a way that, Zeke, is not usual for a health plan. Our organization has 4 parts. One is the health plan part. The second is we have one of the largest physician group practices in this area attached to our health plan. So we're Kaiser without the hospital, basically, primary and specialty care. And we're a social service organization. We have 14 neighborhood care centers in some of the most impacted neighborhoods around our area. And then lastly, we have a national wellness company with almost 1 million people associated with it all over the country, where we're selling services, coaching, wellness services to employers who really significantly need that. So Michael's right. This area was slammed by COVID. We saw it from our health plan perspective, and because of the nature of who we serve city workers, we serve Medicare, we serve Medicaid, we serve the exchange, we serve small employers, large employers, you name it, we serve them. We were slammed, so Michael is absolutely right. And figuring out how you transmute yourself into something that is very different than the model that you thought you were running when you came to work the beginning of March of 2020.
Sure.
It has done something, I think, very, very important in New York, much of it horrific to certain neighborhoods and populations and families. But from a healthcare delivery perspective, I think Michael's absolutely right. We learned a number of things. Our physicians' offices stayed open the whole time. We transformed into telehealth, and I know you want to probe that where we could, but we were there to serve our patients who really need us when they needed us. And our social service organization stayed open as well because we had so many people who, you talked about, Michael, mental health issues, behavioral issues, isolation issues. In one of the largest cities in the world, it gobsmacked us how isolated individuals could feel when they're told that they can't go out, when they have to stay alone. And we developed programs very quickly to address that as well. In terms of what government could do, I think that the tendency, and this is not critically said, the tendency is to spec out everything from a regulatory perspective. You in your talk used the example of quality measures. That's a great example, I think, of what Michael is talking about. We have so many quality measures. Medicare and Medicaid don't jive. Commercial measures don't jive, et cetera, et cetera. If we could only step back, and clearly certain populations need specific measures, but really deal with what makes sense, outcomes. Hold us accountable for outcomes, not process standards. I think that encourages smart people to be very innovative and to do the kinds of things you challenged us in your talk to do, to show this is where you have to end up. How you get there, we're going to give you a little room as opposed to necessarily one thing after another. Telehealth, I think one of the most important things government could do at the national level as well as the state level. We did a national survey in the middle of COVID because everybody, of course, is so excited about telemedicine, quite appropriately.
Sure.
We found that some of the neighborhoods we serve were really impacted in such a negative way from they don't have access to stable Wi-Fi. That seems like a simple thing to say. So the healthcare aperture has to be enlarged. And I think working on stable Wi-Fi, I can go home to 3 devices that just I have. I'm very lucky to have 3 devices, and some days I think I need 4. But many families have 1. That is the device for education. It's the device for Zoom calls, for work. It's the device for communicating with family and friends, and the device for telehealth. So we need to really think about that, and I think that would be a major step forward. I also think that there's an opportunity for regulatory bodies, whether federal or state, to really think about outcomes and value-based, and what needs to happen to support that. What about physicians that don't have EMRs that support tracking gaps in care? How do we help them with that? We've tried to do it through our physician organization. We're all Epic enabled, so we're very lucky in our 40 centers. We can go from one center to another and everything is transferable. But that doesn't happen in every physician practice. How do we help them with that? How do we help them with documenting conditions and things of that sort so they know who is most prone to the kinds of issues and concerns that we face? So for us, community health, Michael, you talked about that. That is priority number one. How, as a health plan, a physician organization, a social service organization, can we better serve the community and really help with disparities of care? Two, health equity. How can we do our part to really address the issues of health equity that I think the Biden administration has paramount in their minds? They've had a few things to get through before they get to that, but I think that's a very, very important thing. How do we give stable access, not just to the healthcare system, but to devices, Wi-Fi, et cetera, that we can go on as policy leaders about synchronous, asynchronous text and coaching and real-time meeting people where they are. But if you can't be met because you don't have the devices or the stable Wi-Fi, we're just whistling in the wind. So I think there's...
So Karen, let me push you for a second.
Sure.
Assume that the broadband issue is going to be addressed in the
infrastructure bill.
Hopefully,
bill.
Okay. That still doesn't solve the problem. And the question for you as a payer is, what can you do to make telemedicine more integral and more sustainable? And I'll just give you a number. I don't know what the facts are in New York, and maybe Michael can enlighten the audience. But at Penn, we immediately, with COVID, April 2020, we had about 45% of our outpatient visits went to telemedicine. By September, it was down to 13%, and today it's at about 13%. I suspect that for most providers in the country, an experience like that is pretty similar. Big bump in telemedicine. We got over a lot of barriers of not using it. Prior to COVID, only 1 in 5 primary care doctors had done telemedicine, and we got over that. But the question is it going to become again, return to a very, very minor part of what people do, or is it going to become integral to the way we service patients? And how, as you as a payer, not blaming the broadband, because that government, it does seem like it's going to do something to take care of. How are you going to make it much more acceptable, or what do you need government to do in addition to the broadband to make it work?
Yeah, I think those are great questions. So let me give you a systematic answer. First, I have two heads. One is the health plan side, one is the provider side. So, and there are different answers for each. On the health plan side, we have opened up our community service organizations to make broadband telehealth devices available to people. We're also now sending out portable devices to monitor blood pressure, do a number of diabetes monitoring, and so on and so forth. So it will be in that mode that we approach availability of devices on the health plan side.
Oh, that's remote monitoring, but that's not an office.
But that is a similar strategy. So just as you give out devices for remote monitoring, you can give out devices to help with telehealth. But what you described, I think, is the modal experience of most practices. People like to have a personal connection with their doctor, and that's sort of what we see throughout our practice. Where you see that not being the case, and here's where I think there's real opportunity for telehealth, and I'll come to texting in a moment, is behavioral. That has not gone down, and I don't believe it's going to go down, because I think people like the opportunity not to necessarily have to sit in front of someone, but to have that protection of a screen. And I think that we've seen behavioral health usage going up as a result of telehealth and enabling that. And so we'll continue to do that. And the other area that we're looking at devices and to enable people to use the system is synchronous and asynchronous text. And I think we've only touched the surface of that It's not, I don't want to mislead anyone, I'm not suggesting we practice medicine that way, but I think for basic questions, basic information, to empower people, you can use devices and texting for that sort of thing.
So can I
Michael,
just let me just add a piece. In the telemedicine, digital care, virtual care, whatever we call it, it's going to become a major part of care delivery going forward. I mean, it's moving forward. It will not be held back. I mean, we had a huge telemedicine program before COVID. It accelerated dramatically because of COVID. And going forward, it will be a big part of care delivery, especially the initial stages of care delivery. And we're going to be, in my organization, we're expanding it, and that's a major growth strategy. And what my job then is I'm going to try to figure out how do I get appropriately paid for it. So I will argue with Karen, how are you going to help me pay for it? Or I'll argue with the government, or I'll take a loss to do it and make it up someplace else. But it's going to be an inherent part of care delivery. Two issues, two cautions. And Karen was saying this. We have to be very careful that as it expands, by the way, on behavioral health, we have huge telepsych programs. We have tele-ICU, tele-hospice, tele-home. But
And
as
people like it.
Oh, they love it, yeah. But especially in behavioral health. But as we expand it, we just don't get so fully addicted to it that we forget the human element, that there is the need for that personal contact. And then to be able to put around it the quality metrics to make sure that if we do telemedicine for this process, that it actually works for that process. And that, I think, will take a lot of innovation over the next couple of years, but it is definitely going to be a major part of the delivery of healthcare. And I think it's a good thing. And so the other point I want to make in general, before I forget, though, is that there is an extensive amount of innovation going on in healthcare locally. And I don't think a lot of the people, and I'm not talking about all, but a lot of people don't understand a lot of the innovation that goes on. That the joint ventures, the relationships, the works that goes on out in the community all the time. I'm very optimistic, by the way, about what we can do going forward. I get annoyed. I don't want to have bureaucrats always look over my shoulder as if I am always trying to do the bad thing. You know, it's like, we have to watch you because you're going to do something terrible. No, I'm not. I know how to do good things well. I'm not stupid. I was been around a long time. I know how to deliver healthcare. I know how to get the business out there. I can open up beds. I can open procedures. I can expand dramatically. Just please, stand back and let me go. And the whole regulatory reform movement is something that is dramatically needed. We have our nurses
Michael,
in our hospitals.
Can I push you on two things? Let me push you on two things.
Yeah.
The first thing is I need to be paid for telemedicine. What happens if the payers say something different? Look, you figure out how to do telemedicine.
Right.
We want to pay you a PMPM. This idea of you constantly billing us, that is like old school. The second is, and I push you on, you said I could do more. I could expand beds. I could do that. All of that raises costs. Does it raise health?
Yes, it.
You yourself may raise the issue of maybe it's not raising health. So the question is, are we entrusting you to raise your revenue, or should we be entrusting you to produce health for a fixed fee?
You can entrust me to improve health, but you also need beds in certain cases. There's a naivete here. We have closed 22 hospitals in New York. I get sick and tired of people saying we haven't made changes in New York. Hospitals have closed all over New York, and we're doing everything every day to move stuff out of hospitals. Right?
Is that a good thing or a bad thing?
That's a good thing. That's a good thing. But it wasn't the government that did it, we did it. I don't need the government to tell me to do things every single day of the week. And so government has a role, but the government needs to understand where its role should stop. And I am willing to do capitated payments if I can, especially with Medicaid and others, if the government can figure out how to do a deal over a 5-year period of time that then allows me to operate within that 5-year period of time in a way that makes sense and not to have every step of the way regulated.
Oh, so you would like something like the Maryland plan for your facility?
No, that's an all-payer plan. I'm not talking about an all-payer plan. I'm talking because I worked in an all-payer plan in New York years ago when I was with the governor, and believe me, that's not something that I think overall, if you define it as, some people use it, single payer, I don't think that's the direction we should be moving in at all.
But
I think you eliminate innovation and creativity when you do that.
But you would like a 5-year plan from, say, CMMI on a capitated amount for your
on the Medicaid side, yes, for sure, because the Medicaid is what I think is needed the most.
Okay.
Yeah.
But not on the commercial side.
We do value-based relationships on the commercial side. I work like that, and with Karen, I do it with United, I do it with Aetna, etc. Yes. But we figured this out. I don't need any. The point I'm trying to make, and we don't need, neither does Karen, somebody who's 500 miles away from the world that we live in, trying to micromanage what we do. That's inappropriate.
I think Michael's right, Zeke, about the 3-year, 5-year trajectory. If you're trying to run something and you don't know from year one to another, we would never approach a hospital or a physician group and say, it's a 1 year and we want you to do value-based, whatever. That's not fair because they have no predictability. And you negotiate, as Michael said, a 3-year to longer, depending upon the relationship and what both parties want to do, with the idea that you have trust in the other side. That's important, number one. And number two, that you believe the other side can execute and you understand things go wrong. And I think that sort of, for me, as we looked at our population, Michael talked about his hospital, our population was extremely sick with COVID. Unlike the federal government made adjustments for hospital payments, there were no adjustments for health plans that were in the Medicare program that might have been slammed by COVID. None. It just doesn't come up. And I think that if we're going to talk about remaking everything, it's not about one side or the other. It's setting expectations, setting outcomes, expecting people who are in the arena, in the ecosystem, to rise to those challenges and to demonstrate that they can. That's what you're talking about, and I think that makes a lot of sense.
There's a difference between, the point I'm going to make is, there's policy making, there's strategy, there's operations.
Right, and that's what we're in. We're in operations.
Policymakers stick with the policy, leave operations to the people who know how to do operations. The trouble is we mix them up. And I'm not talking just about the federal government. I mean, I like what's in the reconciliation bill. I hope a lot of that happens. But if it happens and something needs to be implemented, don't give me 15,000 rules where I spend half my time documenting stuff that is irrelevant. That's my point.
Okay. First of all, I think we are in heated agreement, the three of us. I mean, I said in my speech that if we're going to do primary care capitation, you need 5-year contracts because you need to allow for, people to rework their workflows, create the infrastructure, et cetera. So we're all in agreement. These longer-term contracts are absolutely essential for going forward, and that they're absolutely a bedrock, not the only thing that we need going forward. So I want to ask both of you, do you think that the ACOs provide accountable care organizations, given the fact that the federal government has saved money and therefore they have an incentive to push them further? Do you think they're a successful model for you? Do you think in the long term they're going to be a successful model, or that they're not really that beneficial for the community?
Go ahead. Let me. I've been confused with ACOs for a long time. The concept I get, I would look at my whole organization as an accountable care organization. We're very large. We have all components of care delivery. I'm accountable for what I do. But you know, and we've been involved in ACOs. We have an ACO. It's not you know, I've often defined an ACO as, as any consultant's opinion. Sometimes I have a hard time defining what the hell it is. Let me be honest. Like, I can do it conceptually, but there's so much play being made on it. And when I talked to the guy who actually came up with the term ACO, I said, "Why did you come up with the term?" He says, "I didn't, he says, "It just sounded good. I don't know what it means, but it sounded good." So yeah, we're involved in some ACOs. I like the concept, but I have a hard time sometimes understanding how it all works.
Our physician group is very involved in ACOs, and they are in the process of expanding their participation. But if you look at the slide you put up...
In the Medicare program.
Yes. If you look at the slide you put up, it's not even 1% savings. It's a fraction of that.
Right.
So
No, I
there's
agree.
been so much discussion. Meanwhile, there's a lot of very exciting activity here in New York between us and you and other payers and so on and so forth. So I actually think the private sector has driven quite a lot. And I'm not making the point that the private sector is better than government necessarily, but I do think we have the ability to be a little more flexible. And so if we confront an issue at a bargaining table together, then we can figure out how to solve it. If you put together a structure, sometimes if it doesn't fit neatly into that structure, I think that's challenging. But there's a lot of really cool stuff going on here in New York.
So let me push you, Karen. What do you think over the next 3 years, just to take a time horizon that's probably more manageable, new innovations are going to happen in New York from your organization that are going to impact lowering costs or moderating cost growth and improving quality, that are innovative, that maybe aren't going to happen out of CMS?
I can't say whether they won't happen. I think Liz Fowler...
Well, let's say what you're going to do then.
Yeah, Liz Fowler is a very able leader of CMMI, and I think she will be, really thoughtful about what she funds. We've been through a period during the last administration where that's been largely dormant. I think it'll change, so I think that's good. What we will be focused on is the following. First, when we think about innovation, we think about how do you meet the customer where they are? What do they need? So I'll give you an example. We have a CDC-approved diabetes program. We used to do that in person. We don't do that in person anymore, post-COVID, et cetera. We can go back to doing it in person, but we made it all virtual. In addition, we've added health coaching. I think health coaching is one of the most undervalued aspects of our healthcare delivery system. And what do I mean by health coaching? We used to think about it as care management. People who are clinically trained to answer the phone, to support an individual, to advise them on where they need to go, to work with them on their goals and objectives, et cetera. So we're marrying health coaching with diabetes improvement and a number of other chronic care condition improvement activities, which we're really excited about. Second, we are working with our hospital partners, with our physician partners to really go long on value-based payments. And some delivery systems, Zeke, don't want to go, can't go for infrastructure reasons all the way to capitation. But we have a system where we can accommodate people along the way, whether it's upside to start, and then we get to shared risks, and then that gets bigger, et cetera. That's the point. The payers have to offer skills and supports to our provider partners. We offer data. We have to offer support, in some cases help on the EMR side. So all of those sorts of things, to make this hope of value-based payment a reality. Third, we're really thinking about how do we expand the aperture in terms of healthcare services. So what does it mean to do prevention? How do you do that? How do you make people, how do you make them actually, or encourage them to take an interest in their health and want to go and get that flu shot, go and do a number of things that are necessary, get the mammogram, what have you. So we're thinking about a number of innovations in that space, all the way to palliative care. How do we give people, we spend a lot of time thinking about how we welcome babies here. We don't spend enough time on the other side. How do we make that experience more humane, more supportive, more family-oriented and home-based? And then finally, how do we really think about the home and what we can do in the home? What are the boundaries? And now it's becoming really clear that if we're intelligent about it, there probably aren't that many boundaries. We can be very innovative in terms of taking care to people at home. So those are the aspects of what we're focused on right now.
So if I have it right, coaching, you're going to do some more value-based payment, whether it's capitation for some, upside only for those who aren't ready. You're going to do more end-of-life care and more home care. That's the innovations over the next 5 years?
The preventive care as well. How do we really stimulate that? And the coordination of care.
More self-management on the
More
prevention.
self-management, guided management. How do we use our coaching there to help? We've reinvented our city goal program with our city population, our HMO, really focusing on coaching and support, and it's made such a difference. And the letters and the comments we get have really, you can tell it's made a difference in
So
people's
Karen,
lives.
let me put you on the spot here for a second. Those 5 innovations that you just mentioned, if I come back in 3 years, what do I look at to see whether you've been successful or not? Can I look at your total cost of care? Can I look at your diabetes control?
Yeah, you look at participation in care management programs. You look at transitions of
That's
care.
a process measure. I thought you wanted me to do outcome measures.
No, I want the government to do outcomes measures. You're talking about what do you look at. So if you're asking me as an operator, how do I gauge success? I look at what is the participation rate and then what happened to people. So you interrupted me before I finished that sentence. So I didn't get to that second part. But that's really important. And that's how any leader would look at something. How many people, what did we do, how effective were we? So you look at cost of care, you look at quality measures, you look at patient satisfaction. Did we do the job that they expected us to do? That's the, we talk about the triple aim. That's the triangle of things that you really want to look at. And I would add a fourth, what are we doing to impact the healthcare of our community? We haven't really talked about public health and some of the things the government can do. And I think there's a list of things in those categories, actually, that I think this administration will resonate more with them than I think the previous administration.
Okay, so we can come back in 3 years and look at these 5 programs and see how well EmblemHealth has achieved important outcome changes along, getting people with chronic disease who've got coaching, better prevention. We've got better end-of-life care and better community care outcomes.
Yeah, and changing the whole paradigm of reimbursement. I mean, that is the gold standard here that we have to do as a society. Health plans have a role in that. I see it on the physician side. We're playing a role in that, on that side as well, in leading.
And how long do you think it'll take to get the payment changed off fee-for-service to everyone on value-based?
I think it all depends. My revenue, my cost containment is Michael's revenue reduction. And therein, that's the area that we have to talk about and it's not just the two of us, but anytime Michael sits down with a payer. And so we can have grand aspirations unilaterally, as a company, as an industry on our side, but it takes two to tango, so to speak. And we have to talk about that's why, Michael, I think, I don't want to put words in your mouth, but I agree with your point. That's why you're making the point, I can't do anything if you have a one-year look. That's the point you made.
Right.
I really reduced it down to the lowest common denominator, but you can't, because you can't plan, you can't act, and you can't have any predictability. And that's why we don't do one-year contracts.
I agree with that. Michael, 3 years. What are your initiatives, innovative initiatives, and how are you going to be evaluated?
A dramatic expansion in digital health, telemedicine, dramatic expansion there. A dramatic continued movement from inpatient to outpatient, looking at every possible way that we can do things not in the hospital, but outside the hospital. And we open up facilities like this probably every 2 weeks. Has been a dramatic shift. But I want to emphasize something, though. You're still going to have expensive hospital care because chronic illness is growing. The demographics, especially in this region and many other regions, means the population is aging. We are suffering from a crisis of success. We have done so well in being able to fix people that had problems that years ago we couldn't fix. And also, we've done very well in keeping people alive a long time. So the cost goes up as the population ages and chronic illness increases. And again, it's a price of success. The other thing is a dramatic expansion in home care, but home care where we can kind of a hospital beds at the home rather than having people come to the hospital. We have a huge home care entity. And the other thing that we often forget in all of this is that you're managing a person's care across the full continuum. Like you raised the issue later in your presentation about primary care ACOs, for example. But there's primary care, there's inpatient care, there is home care, then there's primary care again. It's a continuum over a period of time. It's not like I know practices that do very well taking care of patients when they come for primary care offices. But I have to deal at the end with the people that show up from that office in the hospital when they really get sick. I don't keep them back in the primary care practice when they're sick. They come to me. But they can stand up and talk about the wonderful work they did, but I've got the expensive side of it when they leave. So I understand all of this, but you're looking at the continuum. You're managing a person's care over the lifespan, from the beginning to the end. And you got to think that way. So when you ask about, you got to set goals along the way. But it's not like you can take a patient today and in 3 years from now you have a complete final cure. It doesn't work that way because as they get older, other things happen. The other thing is that we are one of the big academic teaching places in the United States. We've got 2,000 residents and fellows, and we've got very, very unique medical school, nursing schools, etc. So it's a dramatic redoing of the educational curriculum. So we teach people in a very different way than we taught before. I mean, all my medical students are trained as EMTs in the first 9 weeks. They ride the ambulances. They're out in the practices from day one. They don't spend the first 2 years in classroom. And now that's happening all over. We were one of the first to do it in a major way. But you have to, and we have to change the diversity of our medical school population so that we get people coming out, where we get African American doctors, black doctors, we get Hispanic doctors, etc., so we can serve those communities with people from those communities. And the other thing I'm working on is with the school systems. I am going to be announcing a major program for school scholarships, and from poor families to allow kids to go to college. Now, that's what I'm doing. I don't get direct reimbursement for this, but to me, it's part of dealing with the social aspects of what it is we need to do to improve health. And I will say this. We will never reduce the overall cost of healthcare until we tackle the non-medical side of the business. So we can show reductions in cost growth on the medical side, but the overall cost of care is not coming down until we deal with the issues that create the illnesses to begin with. That's where we got to spend an awful lot of our effort. Now, it doesn't fit neatly into a box, and it doesn't fit in neatly into a regulatory category, etc. But it's the totality of the health. And one other thing that seems contradictory, but there's a lot of contradictory things in this business. The more we expand access, the more we create demand. The more you go out into communities that are underserved to provide basic care, you enhance demand. The more you expand telemedicine so that when people can access a provider from their bedroom, you enhance demand. So every technology company that comes to me telling me how they have this wonderful cure that will reduce cost, that's not the basic interest, that they want to be able to continue to expand their business. And of course, all of us want to expand our businesses when it makes sense. So it's much more complicated than the neat little packages that people say, do this little piece on the medical and we can say this. It's too complex. Now, that does not obviate and take away the responsibility of us to be accountable, etc. But we got to redefine what we mean by that. Very different from the old traditional way of looking at it.
So in 3 years, we'll have more digital. You'll be caring for patients digitally, whether home monitoring or more telemedicine. You'll do more out-of-hospital care, hospital at home, maybe cancer chemotherapy at home, etc.
We do that now.
And you're redoing medical education to transform both who you're training and how you're training, so you're training them more in the clinical. But I didn't hear anything about payment reform, shifting your payment off of fee-for-service to more value.
We will reform payment, Karen and I with the other payers, and do it the right way, but I'm not going to fall into the trap of fitting a nice pre-prescribed little model that doesn't necessarily work.
If you could wave a magic wand, Michael, what would you like for payment reform for your organization?
I would like to be working with the payers, because I believe that the partnership between the providers and the payers will intensify and has to intensify, where we're able to sit down and look at not just the medical side of it, but also to get reimbursement for the non-medical and come up together with for the particular program we develop, some outcome metrics that we both agree on so that we agree. Yeah. That's what I want to be doing. And we just signed a big deal. It was in the newspapers today. We just signed a big deal with a payer that has a wonderful new payment, value-based payment models in it, et cetera, et cetera. All different, all unique. We've done the same with Humana recently because they're big into the area of Medicare. I've been doing a lot with Karen. Let us figure this out. We got to get away from the transactional process of payment to deal with the holistic payment models. But you can't predefine what exactly it's going to look like. Let us figure it out. But give us the freedom to figure it out.
But if you're going to negotiate, what would you... I mean, I agree. You need to figure it out, but you need to start somewhere. What does a value-based payment look like for you as this humongous health system?
I don't know yet. It's like pornography. I'll know it when I see it.
I don't know that we...
No, I mean, listen. I mean, I don't want to be... But nobody can explain what a value-based payment model is. Because you can intellectually do it. You can do it in an academic setting. It's very different in real life. I'm down in real life. And we will figure out what value-based payment is.
Michael, that's an insult. I'm sorry. I'm in real life, too. I sit on, as I mentioned at the start, I sit on the board of a primary care company. I understand. My own company putting out. I'm in the real world, too. And we actually have ideas about value-based payment that look like capitation and responsibility for total cost of care. That's not vague. It's very specific, and it means that you're responsible for care given a budget.
I understand that. I know exactly what that is, yes. But then I would like to look to see exactly what's included inside that for what span of time over what period. And they're all different, but I'm not
out there. I was pretty specific, Michael.
I understand.
I'm sorry.
And I'm willing to learn from the specificity that you have, but I'm not going to fall into the trap of telling you how exactly I'm going to do it.
Let me help you.
I'm not accountable that way to you.
Zeke, it's a really different proposition, thinking about this from the physician group perspective. I go to a physician group and I say, I have 2,000 members with your group. They know about attribution. So then they can have the kinds of everything all the way to capitation, but they know who they have, who's in the door, how do they manage. They can make some assessments about the predictability of it working. I'm going to help you. Because for Michael, he doesn't have the same, I can't tell him that I'm going to guarantee that 10,000, 20,000, 40,000 patients go into his doors because we don't know where they're going to go. So he doesn't have that attribution. So I'm beginning to actually think about something that with hospitals that would allow them to, and we haven't talked about this, Michael, would allow them to track through their EMRs who's coming in, and then retrospectively think about attribution, which would help make it more predictable, et cetera. Nobody's talked about any of that. But, and the reason I think about that is really spending a significant, we treat 500,000 people in our physician group. And really looking at it from that perspective, it begins to enlighten you. So when I talk about value-based payments, my job is to create an incentive structure that hospitals can work under. They don't feel they're getting hosed. They feel that I'm helping them along this journey that Michael articulated. How do we get people out of the hospital into, whether it's all the way to the home, which we're doing a significant number of things on as well, or, you know, everything in between. So it's just a little different if you're sitting in a hospital versus a physician group because you don't know who's coming in the door.
I totally agree.
Yeah.
And Michael was, and attribution to a physician group, I won't say it's easy,
No.
but it is easier, and you can, again, empower the doctor
Yes, you can.
to
Yeah.
reaffirm their relationship and state who they're responsible for,
Exactly.
and get the patient to affirm that relationship.
That's why there's
Hospital's a
more
bit
capitation there than on the
But
hospital
let me
side.
just say, you can have a global budget
Yeah.
at hospitals. Maryland has shown that you can have that, and it can work, and it can lead to cost savings. So I mean, a capitated global budget is certainly possible. It's not an impossibility.
No, I don't think anybody's arguing that, but just for
I don't disagree.
For sport, this attribution is very important. So if you're a hospital-based system, you're not geared to having an infrastructure like a payer to track everything, et cetera, et cetera. So that's part of what we talk about when we negotiate and we talk with hospitals. Clearly, the incentives from a public policy perspective are to do exactly as Michael suggested, get people out of the most expensive component into the most appropriate component for their disease needs.
Okay, so I think we're at time. In the following sense, we're going to go to audience questions, but I do think that both of you have outlined over the next 3 years the kind of innovations you plan to take and the kind of things you want to be held accountable for doing. I'll try to summarize them to the best of my ability. For Michael, it's more digital, managing patients much more digital, much more out of hospital, even for complex patients, getting them hospital at home, and then a really transformed medical education program that does a lot of trains people for the community from which they came to go back to that community. For you, Karen, isn't that the 3 things you mentioned?
Yeah, can I just say something, Zeke?
Yeah.
One of the areas that hasn't been getting the attention is it's very hard to change the delivery model long-term unless you change the educational model about how you train people who are going to be delivering it.
Yeah, I completely
There
agree
needs to
with
be
that.
a dramatic rethinking of medical education and
Yes.
nursing education.
I couldn't.
And because, one of the biggest problems is trying to, I even saw it in one of your slides about physician autonomy. We have to be very careful what we mean by that. Because some physicians will mean physician autonomy, meaning I'm going to do what I think is right, irrespective of whether it's good quality or not. I've had that argument with physicians over and over and over again. So we have to be careful with, that was a traditional way we trained. You have your own practice, you set up your own office, and you have your total autonomy. But it's a structural issue we have in medical education. I don't think it's getting the attention, because if you're going to do all of the things you talk about, and I don't disagree with anything you said. You said when we had a pre-meeting about this to make it a little bit controversial, so I figured we'd make it a little bit controversial.
I said that?
Yeah, you said that. You said, let's not be boring. I don't want us to be boring. I mean, the hell. I mean, this is
Michael, look, you're talking to the converted.
Right.
In January 2020, just ahead of COVID, I talked about transforming medical education radically in, taking out the first 2 years, making it all online and let people do it as they will, and then promoting people based upon competence, not based upon just time that their butt's in a chair. I totally agree with you that we need to change it, and that's that. It's so outmoded. It's 110 years old the way we train people.
And allowing nurses to work at the top of their practice, dramatically expanding nurse practitioners. We also get constrained by licensing procedures, by the trade associations. I mean, we need more advanced care management. We need new training for what care management is. We definitely need a heck of a lot more people in the behavioral health space.
Yeah, I agree with that.
I mean, I have 2 psychiatric hospitals. I can honestly find a bed, but finding the people out in the community to provide community-based mental health. See, so when we talk about value-based payment, if you don't have all of those tools all in the right place, all of it has to kind of go together. That's what makes it complex. The talent that is needed to transition to where we need to go is not here right now. We need to develop it. If we don't do that, we'll be over our skis talking about wonderful concepts that you can't deliver.
And we used to invest much more in education than we do right now. And I think that is the workforce, and investing in the workforce is absolutely key to dealing with the public health crisis we have, which we haven't talked about here.
Right.
But we have a massive public health crisis. Funding has diminished over a period of 2 decades. We saw the woeful difficulties that appeared during COVID. And the government, that's something I think the government, both at the federal as well as the state level, really needs to prioritize. So I'm all about workforce investment too. I think that's very, very important.
The role of local health departments.
We certainly need comprehensive reform of CDC and the public health